0 to 3 National Center for Toddlers and Families, and a past president of the World Association for Infant Mental Health. She's authored numerous books and publications and performs research, and I'm most familiar with her. She serves as a consultant for Project Safe Start and does training for us also. So I'm sure she's got wonderful things to show you.
Thanks. And Jenny's not only introducing me, but we work very closely as partners on the Project Safe Start, the Eyes of the Child project, and a lot of the efforts in Nebraska. There's a real team here, as well as Mark Held, who was on that wonderful video. He didn't hear me. He's standing over there on his computer. Another partner, and there are others in the room as well. And so the people who came in later had to sit in the front. I was wondering if everybody was going to be in the back. But this is good. We've got a beautiful. Well, I am going to talk with you about trauma, more about trauma-informed systems, different from what I did with Judge Johnson, building on it, and a little bit about the work of the collaboration. We've been working in Nebraska. Originally it was called the Baby Drug Court. I don't know if it's called something different now, but when I first started it was Baby Drug Court, Judge Johnson's court, but there are courts all over Nebraska. Maybe some of you are judges in the room who I don't know also are doing similar things. And then I also have consulted with the Safe Babies Court team, which I believe we're now in 10 jurisdictions, but we've been in 11 jurisdictions in various states around the country, and learned a lot about different ways the collaborative model can be put together. One of the things I was actually asking Judge Payne about earlier is about the issue of rotating judges. That creates problems with trying to set up these specialty courts, because once you get your collaborative group together, you hope that most partners will stay here, particularly the judge, who's crucial. So I'm going to talk a little bit more about trauma, and then some of the kinds of things that we need to look at in the partnership. And a number of you came up to talk to me after the plenary, both judicial, early intervention, mental health. Those are all partners, and I think having us all kind of on the same page and supporting each other with this work makes a big difference for the children. So one of the things that we didn't do before, I always do, and people who've heard me train know I always do this. I really like my definition of trauma. It's not my definition. I really like talking about a definition of trauma, because we need to know what trauma, how it impacts on children or adults. And here we're talking about young children. And the problems young children have, there's plenty of seats up here. The problems that, and you don't have to come all the way into the front. The problem that young children have is not only can't they communicate how they feel, but they depend on adults in their environment to not only keep them safe, but for their optimal development. So if they don't have that consistent experience in the first year of life of learning to be able to trust and learning how to cope with their environment, then they become overwhelmed, and that's what trauma does. And so when we were talking earlier, Nick was already 4.5 years old, but you see this in babies in the first year of life and the second year of life, where they just can't control their emotions because of the trauma that they're exposed to. And older children also obviously get dysregulated and have difficulty controlling their behaviors and emotions, but they're not as dependent on adults. Now, of course, the problem is when you get a 4.5-year-old like Nick, without consistency early in his life, it's much, much harder to help him learn to trust. And we see that, and we see that in the court cases where these young children have been in multiple placements, that type of thing. But that's what happens with trauma. And you saw this before. I'm just putting it up again. I quite like this, actually. A colleague of mine, and I worked on this, someone who was at the Development Center in Houston, because listing them is different than looking at them that way. And it also gives you this view of cumulative trauma that's very, very important. And then it would be unlikely that a child in the child welfare system had not been exposed to multiple forms of trauma. And the majority, as we know, is neglect. in the child welfare system. So you sort of have to assume neglect probably goes hand in hand with the other abuse. This is just some data from the National Child Traumatic Stress Network across 25 states. The average, and if we go back, I don't remember, I revised this to take out some things so it wasn't redundant. I don't remember whether I left the ACEs thing in here, but you all saw the adverse childhood experiences. So from this data on 1,700 children across 25 sites, the average exposure was to 3 trauma types. And the average age of onset is 5 years. So it starts very young and very important for the work that's done here. The other thing that I think didn't come up in the plenary that we were talking about, that I was thinking about this morning, is that a lot of people think children are too young to be impacted. The really young children, the first year of life or the second year of life, and they're not too young. I saw a really interesting video that someone had in the last 6 months. I can't remember where I saw it. But it was actually a 2-month-old baby on a foster parent's shoulder, and when the father walked in the room, the 2-month-old went like that, which is pretty unusual. Might have been 3 months, it was really young. And then the father left her and came back in, and the child did the same thing. I had never seen that kind of response, but we have, and I have video actually that I can show you of an 11-month-old showing fear in seeing the mother who had physically abused her. So I think that's one of the reasons that young children also aren't paid attention to that much. We also need to think about the effect on parents. So not only does it affect all those things in the child, but it also affects the parents' functioning. And I think too often we think because they're adults, they'll be able to move on, but actually the case I mentioned earlier, we have a new case with this little boy who was totally out of control, and mom was bringing him in for help. He's 3 years old, and she did not think about the fact that she was living and had been living in a very violent domestic violence situation, and the little boy was out of control. And it didn't dawn on her. So traumatic stress affects parents' functioning as well as the child's functioning, and we have to bear that in mind. We've got that dyad. So this is just another one of the brain slides, and we didn't have that one up before, and I thought you might like to see that. Actually, the slide of the abused brain, from what I heard, was from an orphanage with severe deprivation. And even if one isn't a neuroscientist who doesn't know a lot of neuroanatomy, you get it when you see that kind of thing in terms of how experience impacts on the brain, the neuronal connection. So what happens to a caregiver if they're exposed to trauma? And what happens to them in terms of parenting? They have difficulty listening to their child. They're very stressed. They have distress. They need to protect themselves from feeling vulnerable, and they have trouble hearing the child say. So you've got a dyad, where the child needs more. That's one of the reasons we talk about the need to really help support foster parents. And I know there are a number of foster parents in here that come up and talk to me, but these children can be more difficult to handle. I was actually meeting with a group of foster parents in one of our 14s, which was in Hawaii. Hawaii always sounds wonderful, but when I go to Hawaii, we start working about 7:30 in the morning and then about 9 o'clock at night, and I usually get up early enough to get a walk on the beach. But when we met with the foster parents there, they were talking about how hard it is for them and how hard it is to deal with a child's distress. And 2 of these foster parents had recently taken in cocaine-exposed babies who were very dysregulated and cried a lot, and when they didn't cry, they slept, and none of that alert attention that you need to be able to build a relationship with a baby. And so they were kind of beside themselves. They had both raised other children that were not cocaine-exposed and just didn't know what to do about all this dysregulation. And so they actually formed a group and talked about it, and actually got someone who had a lot of fair amount of developmental knowledge in there to talk about it. And somehow when they learned that there wasn't anything that they were doing wrong, and some of the kinds of unusual things that would soothe the babies, it really helped them a great deal. And that was such an important lesson. Granted, those are babies who are much, much more difficult, but many of these children, because of the trauma they've been exposed to, are going to be more difficult when they go into foster care. And even if their difficulty is not so much externalizing aggressive behaviors, it can be internalizing withdrawn behaviors, and the parents need help dealing with that as well. So in case you wanted to get a closer up look at the ACEs study, that's what it looks like. It's really quite remarkable. Judge Payne and I were talking about it before. He didn't know I was going to present on it. But people really pay attention, and they pay attention because of the health risks, I think. You know, because everybody in this room knows, for example, with delinquency, you know, all of those children have been exposed to some kind of trauma, probably abuse or neglect or something else, but they've been exposed to trauma in probably 99% of the cases, you know. But what about the cases where they're exposed to trauma and they don't end up going in the negative direction? You know, what are the factors that impact on it? So this isn't something that you know, has to result in that way. It's just the greater risk related to all kinds of problems. And if we look at some of the detail there that you couldn't see before, on the disease and disability side, I mentioned depression, suicide, PTSD, alcohol abuse, that's all expected, but heart disease, cancer, lung disease, intergenerational transmission of abuse, and then all the social problems on the other side there. Can you see if I'm standing here, am I in the way? Homelessness, prostitution, criminal behavior, unemployment, a lot of the kinds of things that you all see, that we all see coming into dependency court, or delinquency or juvenile court. So I think that we need to pay more attention to that. And if the risk factors go up, and actually I was talking to Judge Payne after, and we were saying, look at some of the risk factors, you know, and it's a little bit scary because all of us have been exposed to some risk factors. You know, even a parent loss, not a parent loss like what we're talking about in child welfare, but a death of a parent has its impact depending on the stability that there is in the family after that point. Okay, I wanted to go through just a few of the details that the Child Welfare Committee from the National Child Traumatic Stress Network have in their trauma-informed child welfare system of care. And there's a lot of training. A number of states are participating in training. Did somebody fall? No? Okay. So, back to trauma informed child welfare systems. That's going to have to go on there.
Yeah, I said we planned for a lot of things, but that was not on our contingencies, so.
Okay. So, recognizing and responding to the impact of trauma. We also have to recognize the trauma on service providers as well, and caregivers. Really need training so there's awareness of trauma and skills. A number of people came up and asked me about trauma screens. And there are a number on the National Child Traumatic Stress Network. A lot of people use the UCLA PTSD screen. We're using that in some of the work we do now. We've added some questions related to depression for our disaster work. But if it's possible to do a screen, that could be really important to know about because it gives you information and then, you know, where you go from there. And then, as we say, collaboration is very, very important, and science is important.
Can I ask you a question? When you had given your presentation and when you talked about the trauma, like a screen, checklist or whatever, I think, is that something that you have? Where do you locate something like that?
Yeah, that's what I was actually just no, that's fine. I just, the UCLA PTSD screen, you can look it up, the UCLA PTSD screen, but I would suggest looking on the National Child Traumatic Stress Network website. It's www.nctsn.org. where there are a lot of screens. I know that, and we were talking about, Judge Payne and I were talking about in the Ohio, some of their juvenile courts, they're using the PTSD, UCLA PTSD screen, which is pretty, you need something that's short. But then also you need to train people, if they're going to use the screen, what to do with it. I was saying that we're working actually out in primary care now, just starting to initiate that work. Actually, it's going to be even more of an issue with the additional trauma that's coming these people's way, but you need to know what to do when you ask the questions. Yes?
So when I order a complete psych screen, kid or a parent, I'm not going to get that info.
If they're trauma informed, you would get information about trauma, but if they're not trauma informed, no, probably not. If you ask for a psychological evaluation, yes.
The second question, if I order it, will the department pay for it? What?
The psychological evaluation, well, it's easy to do a trauma screen as part of your evaluation.
So far, they don't let judges do that.
Yeah. But I think it's a really good question. And a trauma screen could be done as part of a psychological evaluation. It also could be done in child welfare if they're trained to do that. I mean, for a child to learn more about the trauma they're exposed to. I don't know who we have in child welfare there and how you feel about that. Someone came up to me who does early intervention in homes, to find out about trauma. And I'm moving toward talking about a collaborative group, because, for example, if somebody screens for trauma, but they don't know what to do once they get the information, that can be certainly problematic. I've worked with, when we, for example, taking it out of the child welfare system, with our disaster work, people were in the field, and, we're trying to ask certain questions. Well, then, sometimes, not often, but there was answer about somebody being suicidal, and they didn't know what to do. So there always has to be a protocol in place. Now, that's not something you ask on the trauma screen, but the person came, we were doing a consultation supervision with them. They've been in the field, and they said yesterday she had interviewed someone who said he was suicidal and told the person that she would be back tomorrow, and we gasped, because that's not the appropriate response. So if one's going to get the information, it has to be training, in terms of backup and what to do with it. Yes, sir.
Does the person doing the screening have to be trained, or can the trauma screening thing be given to and filled out and then used later? Or?
Absolutely. The only issue about doing a trauma screening is it's good to look at it to see if somebody is endorsing a lot of things that would be a concern, as opposed to doing it and just leaving it to someone, a couple of days later. But that's easy enough for someone to know. We look at the number of items that they endorse.
So it could be done it could be done without somebody who's not trained, or given to somebody who is trained. But then, of course, the risk is that there's something that should be done immediately. It's not being done.
Yeah, and what we actually do, we work in schools and collaborate. Some of the work we do is in schools and collaboration. We do a screen for post-traumatic stress and depressive symptoms. And we'll try to look to see if there are too many things. Yeah, we don't have to be trained in terms of mental health. There has to be a system in place. We use that, but on the other hand, if we have someone who is supposed to on town and doesn't know about it, that would be contributing to all kinds of things in our being addressed. We talked about the example of the domestic violence, where a woman chooses one partner after another. Well, that's the woman who is supposed to tell us something really important. But yeah, they're really good questions, and I think that's why we're talking about, how to build that collaboration. Okay. And some states have taken on, and child welfare systems getting more of this training. related to being trauma-informed. And that spreads easily through the system, you know, in many ways. There are a lot of resources available on the National Child Traumatic Stress Network that are really useful. We also need to look at protective factors, and we have that on there because that's very, very important, the strengths in families. And also the child welfare system training and awareness also speaks to the issue of secondary traumatic stress and people who work in the field, because what happens if you don't address the issue of secondary traumatic stress is you can get burnout, more burnout, and we know there's a lot of burnout. And you know, there certainly are many people where I know, I don't know what the load is in the child welfare system here, but have a huge number of cases. And that contributes obviously to burnout, and sometimes it's unavoidable. I see some smiles there, so I have a feeling that some people may have a huge number of cases.
I'm still stuck on the snake.
What's that?
I'm stuck on the snake.
Oh, you're stuck on the snake. Okay. All right. So I wanted to talk a little bit about a collaborative partnership, and I'd like people to participate with me in this conversation because I learn about parts of collaborative partnerships that we may not have thought about or may not have learned about, and then I was going to show you a case that we've had in our court in New Orleans, an interesting case of domestic violence with a father involved. And I know Judge Payne is talking about, you know, fathers aren't often looked at enough. And we actually work with a fair number of fathers, not that many in child welfare. In our military work, though, the majority of my cases, the majority of our cases are fathers as well as mothers, which is interesting. So this is the collaborative partnership that we've all been using through Safe Babies Court Team, similar to Safe Start program here and others, and you might want to add parts to it. And I think I have all of the partners listed here that are part of the collaborative, and we talked about working in collaboration. So for example, the issue that was raised, can someone do the screen? Someone could do the screen, but then share it with someone else. The person for early intervention was asking me about a screen. You know, and then certainly people in early intervention who have relationships with people would be very good people to do a screen. On the other hand, if there's something on the screen where they need some mental health backup, they need to be able to have that too. So that's very important. So with these collaborative partners and with being trauma-informed, they all need to have training about how to be trauma-informed or information about being trauma-informed. And you don't have to go through a big training that we set up to do that. There are a lot of materials together, and a lot of materials available, like on the NCTSN website. That's a particularly good place to find them. The information that's on the Center for the Developing Child website, Center for the Developing Child at Harvard, has a lot of information about trauma and stress. And so it's a matter of becoming aware of it. And then for people who are going to interact directly, not being afraid to ask and not being afraid of the answer when you get it. And knowing, you know, how to be there and hold that answer, and knowing when you need more support for that. But you know, I know judges who will ask in court about the experiences that a mother's had or a father's had or something like that. You know, I mean, not in a huge formal court setting, but in certain circumstances. Very important for CASAs and GALs to be aware of trauma. It's one of the things that those of us who do the mental health work are often talking to the GALs about, or the CASAs. Very important to recognize that and how that impacts on behavior. Obviously, child welfare, infant mental health professionals. Most mental health professionals do not have training in working with young children. And most community clinics, if you go to them, they don't really know what to do with children under the age of 5. And it's very frustrating in many ways, because you don't want to wait till a child is 5 years old if a child is having a problem. And you don't want to wait until they get in school for the problem to be identified. So we're trying to work on getting more of that training in the mental health field if we can. As I mentioned, there's a good initiative going on now related to social work training, being more trauma informed and also dealing with issues of younger children, but not much in psychology, very little in psychiatry. And counseling, there isn't much either. Early intervention, very important group. Childcare, particularly Head Start and Early Head Start, but other childcare, because these children need the best childcare. They benefit from better childcare. Healthcare, a medical home. I'm wondering how often, we have a number of judges in the room, I'm wondering how often when there has to be a placement of a child, there's a way to get consistency of medical care. I don't know if that's so that the medical record can at least follow the child. I don't know if that occurs in this state. But that's very, very important. You know, the other reason it's important is that if there is consistency in medical care, some consistency, they can pick up difficulties that occur with the child as well. And dental care, most of the parents haven't had dental care, at least a lot that we come in contact with. Actually, there's another collaborative partner, the foster care system that I don't have up there. Other partners? And for the judges in the room and lawyers, not that I want to put you on the spot, but do you have the opportunity to work with these kinds of partnerships? Yes, I see nodding heads. Some, and others are thinking about it.
What are you bringing the foster parents in for?
I'm sorry?
What are you bringing the foster parents in for?
Well, they should be part of the collaboration. When we have staffing, some cases, because the way the state babies court works and the way it works here, is usually staffings, we have staffings weekly, but not staffing with all the partners once a month and hearings once a month on these cases. The foster parent has to be included at some point, not necessarily in the big meeting, it depends, but support for them in terms of what's going on with the child, decisions that are being made, how they could relate to the bio parent, those types of things. Because there's some states that are doing more of that, and it really is helpful if that can occur.
Well, they have to have an understanding of why the child's behaving this way or those kind of things too in order to direct that.
And I'm not sure how much, I don't know, I really haven't been involved in training for foster parents. We get to meet with them sometimes. I'm not sure how often trauma is discussed. I know whenever I come, we talk about trauma and the experiences the children have. But that plays a big role in, absolutely.
And we also get information from them about the child's behavior across different settings and different relationships, which is helpful in our staffings. So,
I mean, the more information the foster parents have, the more likely they are to be able to do a consistent job with the children as opposed to giving up when they're so difficult. That example of those two foster parents with the cocaine-addicted babies who were very dysregulated, they felt the support they got allowed them to take care of these babies. So, yes, sir.
What about law enforcement and their past contacts with parents?
Yeah, that's very important. We actually haven't, I don't know how many of the groups have law enforcement as part of it. It's obviously particularly important with domestic violence, but also with abuse and neglect. So law enforcement would be a very important partner as well. We worked for many years and have worked with law enforcement related to talking about issues with young children and trauma. And when I first started doing that, they really didn't pay much attention to us. They didn't know why we were bothering them with children and trauma until there was a shooting. And then that's very important. Yes?
I was just going to offer that in Nebraska, we're seeing an increase in public schools offering early childhood programs that may or may not be connected with Head Start or Early Head Start, so they would also be partners with. And plus the fact that we're on for mandate states, so if there's any delays of the child in the school, we're responsible for providing services.
Yeah, that's very important. And then some schools actually incorporate Head Start or Early Head Start or have younger children in the school. Yeah. we've actually been seeing quite a few 4- and 5-year-olds just with our schoolwork.
Is it important that you, the collaborative partners, do you more, maybe I'm not asking this right, but you want to make it so that it's case specific? I mean, there's certain partners you would need for certain cases, or that's who you want to bring in. Do you look at it more that way, or do you just have your generals, here should be, who should be involved?
It's a really good question. I don't think the people in the back could hear. The idea of the collaborative partnership, is it specific to particular cases in terms of the needs, or is it the same for every case? And I would say it's the former. There are certain partners who you always need to have at the table. The judge, and the judge doesn't, jurisdictions vary, I've learned. Sometimes judges are at various kinds of meetings that we would consider to be staffing meetings, not in our case, but certainly the lawyers for the parent, the lawyers for the child, the state's attorney, they all need to be there. Mental health needs to be there, child welfare needs to be there all the time. And then, if there's an issue with early intervention, they ought to be there. If there's an issue with child care. The other thing is, if you have them as partners, when you need to push a little bit for a child, it helps because there's that whole partnership. The other thing that's very clear is if the judge, wants this collaborative group to happen, it's going to happen. I mean, the other thing that does come up, which I think actually we don't have good data on cost effectiveness. We have overall data on, the importance of early intervention and early education and all of that, and cost effectiveness. But one would say with more frequent staffings and more frequent hearings, is that cost effective? Well, it is, because you have permanency quicker. They're less likely to come back into the system, and all of that is cost effective over time. We need to just be better at getting that data to show that. There's good data coming out of the Safe Babies court teams about permanency being much faster and not re-entry back into the system. Yes?
What you're describing comes pretty close to family drug court protocol. And phase ones were there every week. Most of those people are there. In a regular proceeding, we'll have most of the parties there, usually the healthcare providers. But we keep it pretty open. We get input from the parents, all the attorneys, foster parents. If the kids open up, we receive, view statements. Sometimes they're very telling, sometimes they're amusing. That a 9-year-old sent me a note and said, I've got important things to do today instead of going to court. Besides, court's boring. That's not where I stand.
What about the young children? The same model? Well, not for family drug court. It's whoever's in, we've got a lot of information. The rest of it, it's a big debate for a long time is how old should these kids be before they attend court. And once upon a time they were talking about 12. Some kids are ready way before that. We've had 5- and 6-year-olds feel like they're entitled to stand up and tell me. Well, I know some of the dependency judges like to have the young children come to court too. And it's interesting with what you're saying too. It's in terms of the partnerships. I worked with a rural jurisdiction in Louisiana where they did juvenile 1 day a month. And one of the reasons I got involved with it was we were working in the schools where there was a huge amount of truancy. And the schools just didn't know what to do with them, and the kids were truant, and then the court docket was huge on that 1 day of juvenile, probably 6 hours, and huge numbers of truant cases. And so I said to the school, have you talked to the judge? And they hadn't. And so I said, well, is it okay with you? I'm going to go talk to the judge, and had a meeting with the judge. And, said we work with the schools and know there are a lot of truancy cases, so anything we can do would be helpful, because we were providing mental health services at that point under a grant. And I said, is it okay with you if we sit in juvenile in court? Sat in court and started at 8 in the morning, and like at 5:36 in the evening it was still going on because of the truancy cases till like 8:30 in the evening, 9 o'clock. And the judge secretly up to the bench and said, if you provided some evaluation on these cases, would that be helpful? I said, well, we'll be glad to do it, and then you can decide if it's helpful, But what happened over time was, because we had reached out to the court, the school got involved too, and we were doing evaluations that helped the whole family situation, and the truancy rate went from, dropped by 70% or something. It really was remarkable, but it was a partnership that they hadn't thought about. So that's with children who were a little bit older, but it was really important.
I was just going to say, in our family drug court, and I think Felicia Henderson's in here, in Lancaster County, we even have the young children, like the babies in court, and our well-educated court team has started noticing things like the babies reacting to mother's stress during staffing and a hearing, and so it's been a good experience for us to even have very young children, infants in our court.
The problem we have is then getting the child away from the magistrates, clerks, and
we did a little bit of that too. So.
Right. So, yeah, and I have certainly heard that and experienced that, what you're saying with the family drug court. And the reality of the matter is that collaboration, I'm not a judge, but I know collaboration in some specialty courts is easier than collaboration in general, but it also really moves the cases along in an efficient way. So I don't have to, there are not, everybody knows, obviously there are judges here, but everybody else knows about the Adoption Safe Families Act. I'm very surprised sometimes when I do training that people don't know about ASFA. So, okay. Well, this is an interesting one. Does everybody know about the work of Kathy Whittam? Probably not. The link between dependency and delinquency. So, child abuse increases the odds of future delinquency and adult criminality by 40%. This is actually longitudinal data and it's been supported. Arrest as a juvenile by 53%. Arrest as an adult by 38%, and arrest for violent crime by 38%. She did work for the Department of Justice related to violence. And this is for judges who haven't, and lawyers and all haven't dealt with little children, but just deal with the delinquents. This is very important data. People know that, most people. Okay, so I thought it was worthwhile to put up some of the national organizations that have been really helpful. We have, you obviously know about NCJ, but we have a judicial consortium within the National Child Traumatic Stress Network, and NCJ plays a role in it. I've gotten 0 to 3 involved with it. And it's really helpful to have judges, mental health people, education, all different kind of people dealing with how to build the collaboration and inform the work, and that's why we moved ahead with so much progress. So these websites are all really helpful. And I know that I've heard recently, which is important, that NCJ also has a subcommittee, one of your subcommittees dealing with military families that are appearing in the court, because in various states where there are a high number of installations and multiple deployments, there seem to be more military families who are ending up in court because of abuse and neglect or domestic violence, and the special issues related to military families is not always recognized or dealt with, which I think is really important. Not that they're going to have different treatment in court, but recognizing the other issues that are going on in military families. So some of the kinds of things that are part of being trauma-informed is issues about, for example, multiple placements, the negative effects of multiple placements.
Projector went off for some reason.
Oh. Well, I can talk, I didn't need it for my video.
Oh, I think it just came inside.
Okay, I'll talk through this one and then we're going to look at the video. It'll come on in a minute. So one of the issues with multiple placements is it also depends, there are developmental issues that go on. So obviously it's much better to do all of the, when the child is adjudicated dependent, to do studies of all of the relatives and all of the potential places, work with foster to adopt families because of the impact on development. And also monitoring placements. There's not just monitoring of kinship placements. So that's very important as well. Okay. It's fine. Some of these things I don't need to talk about. Then Part C, and everybody in this room knows about Part C, right? All the judges know about Part C and the federal entitlement, although I hear they're cutting back on it. Individuals with Disabilities Education Act, where every child with a 25% delay in at least one area of development is entitled to an evaluation. I've heard some states are cutting back money related to early intervention, but I know that often, or at least a number of years ago, maybe not any judges in Nebraska, but judges in other states don't necessarily know about that entitlement. They can order it and it'll happen, and then services are supposed to come with that. We've talked about the importance of childcare, and there's good data related to that. And then visitation. Visitation is an issue. So we had, first of all, more frequent visitation for young children is very, very important. And there is, with more frequency of visits, reunification often occurs faster. So they should be as often as possible, as long a period of time as possible, obviously safe. But I think that whole issue of visitation is complicated. Because, and I brought this up, I was talking to Judge Johnson yesterday, so who's going to transport for visitation? And if young children are transported by different people for visitation, that's going to be traumatizing. We had a situation of a 4-year-old we were seeing in therapy. And when our therapist walked out to put the child on with the worker who was picking her up, it was a different worker than usually came, and the child froze. You know, I'm wondering how often this kind of thing happens. And so our therapist walked over and said, "What happened to Jane? She was supposed to pick up the child." This, by the way, happens in situations with low-risk children, where they're supposed to be picked up at school by somebody and a different person comes. You know, people don't realize how traumatizing that. It's okay if they know a different person is going to come, but that kind of consistency is very important for young children. So our mental health person spoke to the worker and said, "Where's Jane?" And they said, "Jane got sick." And so I'm taking the child home and said, "Well, the child doesn't know you. Are you a friend of Jane's?" And she said, "Yes." And I said, "Well, the child is frightened. So how about we take a little time, the child get used to you. If you're going to do the right," that's fine. And then she went back and talked to the child. It's a different person picking you up because Jane was sick, but this person is a friend of Jane's and will be okay. And the child was fine. How many times do we ever do that for young children? So that's very important as well. And then preparation for transitions. Transitions are hard for a lot of people. Some people in this room, by the way, will have difficulty for transitions. Others, transitions are very easy. Well, same for young children. For some, transitions are okay, but on the other hand, they need to be talked to, and they need to be supported in transitions. You just don't move them without talking to them and explaining to them what's happening, that kind of thing. So that's very important. If the child can be in the same geographic area, if they can be in the same school, if they can be around familiar people, that's obviously going to be less traumatizing. Okay. We refer for, I'm not going to go into child-parent psychotherapy. I talked about it this morning. Jenny can give you a lot of information about child-parent psychotherapy. Mark can give you a lot of information about child-parent psychotherapy. There are a lot of people in this room who have been working with us on child-parent psychotherapy.
I just have one question about
Yes, of
that.
course.
You showed the picture of the brain after exposure to trauma and those kind of things in young child. after treatment? Are those areas that have been shut off before reactivated, or is that going to be their organic functioning as they continue to grow?
That's really a great question. And actually, in the first video that was made by 0 to 3, Helping Babies from the Bench, there is an implication, that once a child develops to a certain extent, it's difficult to change. And the younger the child is, the more plasticity there is in the brain. After the kind of intervention we're talking about, yes, that should influence the brain in many ways. As their behavior changes, as their emotion changes, the brain changes as well. The younger, even more plasticity in the brain. And I think that's a really important part of the intervention work, the kind of relationship-based work we're talking about doing. So for example, that case that Judge Johnson and I talked about Nick, if they had worked together with that father and Nick, helping father with whatever his issues are, but working them together and helping them slowly with their relationship, I mean, Nick's a little older, not that 4.5 is that old, but there's a lot that's happened to him along the way, so it's going to take longer. But yeah, absolutely. It can change. And Bruce Perry, actually, I think is coming at some point soon, talks about use dependent in that area. So yeah. And it's exciting to think that you can do something like that. Not just change behavior and emotions, but they change because of the changes in the brain, the neuronal connections. The one other thing I want to comment on is parenting programs. Parenting programs where people sit in a room like you're sitting in a room to be taught parenting doesn't have much effect. It needs to be interactive. Children need to be involved. There are many evidence-based parenting programs out there, but it's taken so long to have there's difficulty in the relationship that it really requires interactive work in that way. Do you have any parenting programs that are used generally in Nebraska?
I think some places are using nurturing parents and celebrating families.
Mm-hmm. Yeah, so that's just important to know that there are differences in terms of parenting programs. So these are just some of the intervention and prevention strategies. So I wanted to actually show you a video of a case that we had with the court. The child was exposed to extreme domestic violence. Father was the perpetrator, and the child was very afraid of the father. And we have a series of videos where we worked with the case, and you can see some of the work that we did to help with the relationship with a young child. And we don't have that many fathers. We need to pay more attention to fathers. But also the idea that I think somebody else would have given up with this, and actually we were able to rebuild the relationship. He also worked on his domestic violence. So I would like to just look at this. Well, that would be very important. This was a very challenging case, and if the contrast with the first video I showed you and this video, over a period of about 2 months, we knew that we needed to give it time. We knew he needed the help with parenting and that type of thing, and I think it would be very important actually for people who are out there to be able to look at videos we learn from our observing and to be able to see various approaches that can be used over time. The reason this one is particularly interesting is because we were able to see the sequence of the child being so afraid of the father and remembering to the warm-up over time. The child was also afraid of the mother, and a lot of patience that's required. But that's what we do with the child-parent psychotherapy, and what we would do for the court with a case like this. So they wouldn't see the videotapes. We don't encourage videotapes in court because we interpret the tapes, and you can interpret those tapes in all kind of different ways. We would describe what's going on. We would, in our report, talk about the observation that the child, we'd see where the child was developmentally. She was a bit delayed. But then we would describe what we see, and we describe the progress for the court. And there now seems to be, they're able to learn to keep her safe, they're able to learn to be with her, and this was not the end of treatment by any means. So that when a decision's made, you can feel reasonably comfortable. But that's because of the collaborative group.
Now, how do you make a decision about, we have what's called parent-child interaction therapies, which is being more widely used in our area. So how do you make a determination about which case that you would do that with, or do you guys do that with every case?
We do child-parent psychotherapy with all of the cases, but parent-child interaction therapy isn't used for the very young ones. This was a very young child. Goes down to age 3, right? Yeah, so that would be why we would use child-parent psychotherapy here. We tend to use child-parent psychotherapy with, up to age 5 anyhow. But these are all younger children, 5 and under.
Do you do this for every single one of your cases?
We do. We work in the relationship in this way with the cases. The difference for the people who aren't familiar with parent-child interaction therapy is that it's more behavioral, kind of telling the parents what to do more. Here we're waiting to see what unfolds and trying to work with them. Did any of you who do child-parent psychotherapy have any comments about this case that might be helpful for anybody else in the group? Since you said, the concern with keeping the child safe, we weren't sure that we were going to be successful with this case. And you don't let that go on too long, but it was an interesting progression.
Was that second flip the second session?
No, there had been sessions in between. Yeah.
So that was real slow steps too.
Right. Very slow steps along the way, but keeping it short so that the baby didn't get re-traumatized. Yeah.
How do you use this when you know that the parent is physically abusive to a very young child? I mean, so you've got, kids with bruises or broken bones or, any of those kinds of things. Have you used this therapy and really been able to repair that kind of relationship?
That's a great question. And I have to actually look back at our cases. What I was going to say is if the court orders it, this is the therapy that we use. I'd have to look back and answer that question. Depending on the severity. It seems to me most of the cases where they make this. It's in order to do the court may make a decision as to Yeah, that's a really good question.
We have a lot of cases where a child will have broken ribs and broken bones in various stages of healing. We don't know who did it. Sometimes we don't know if it's the parent, sometimes we don't know if it's a careful.
Oh, yeah, we work with families like that. Yeah, we see families like that. Sometimes they're poor families, and they show up from the hospital and then they're referred to us. Yeah, we work with people like that. Working in the relationship, we find it really helpful. In the sense that not just keeping the relationship, but also as the parents really involved with that. Or being there on other comments? So one thing I wanted to mention on one minute left is the importance of cultural issues and cultural differences, because there are ways that you might work with certain families and then it might not be comfortable for other families, or everybody has different cultural experiences. We do use child-parent psychotherapy with our Cherokee 14 in Cherokee, North Carolina, and they also use some tribal customs at times that have been very helpful. Tribal customs, just, like a blessing for the baby or that kind of thing. So I thank you very much. Those are good questions.